Hello, everyone, and welcome to UroNurse. We meet live every Saturday at 9 a.m. Central Daylight Time. My name is Vic Sinise, and I'm the host for today's show. If you're watching this on YouTube, you can learn more about us by visiting our website at uronurse.com. Our first half hour will be devoted to general questions, and in our second half hour, we're going to take a deeper dive into a subject. Today's subject is going to be office anesthesia. To submit a question, simply click the Q&A button and type in your question. We have a great panel of experts here today to start. So let's start by introducing Lori for the meeting. Go ahead, Lori. Go ahead and introduce yourself.
Hi, I'm Lori Atkinson. I've been in urology for 24 years. I've been certified since 2003, and I work at Northwestern at Delnor in Geneva.
Very good. And I'm going to start today with some questions that are follow-up questions to the previous meetings that we've had. And thanks for everybody who's attended. We've had great numbers of people watching this from our website. Our uronurse.com website has our previously recorded. So video on demand, whenever you want to watch them, they're there. And they're being hosted on YouTube. So we're getting some extra viewers coming in that way. Actually, 18 people have subscribed to us on YouTube. So I think they're starting to follow our channel. I found out if 1,000 people subscribe, I can actually monetize through YouTube. That's where these YouTubers make their money. I don't think that's going to happen, but who knows? But here's a follow-up question. Actually, one that I put in that PSA talk for PSA and prostate biopsy. Is ISO-PSA the standard of care? And I was discussing this with one of our physicians, one of our urologists yesterday when I was in the office. And he was saying, it's really not the standard of care. He said that he's slow to try things. Now, one of the other urologists is all on board with it. He said, I'm kind of slow. He says, I wait till it's the standard. He says, look at how many tests have come and gone and not held the test of time. He said, really, outside of PSA, the only other test is MRI. He says, if you look at MRI right now, he says, that's really kind of holding up. He said, he says, I guess if you have a patient who's on the fence, you might want to, start. He says, he'll start with ordering MRI on somebody and use that as kind of a testing whether they should go through with it or not. And I was giving him a scenario where patients already had prostate biopsy, showed prostatitis, and the PSA just bumped up a little bit. What would you do? And I said, wouldn't you just get an ISO PSA? And he says, yeah, I probably would in this case, but I'd start with an MRI. So actually I told that's a personal friend of mine, and I told him to go ahead and tell the urologist to do that because he doesn't live near me. I had another follow-up question from Jennifer Nygaard, Astoria, Oregon. By the way, you guys are coming from all over the country. Great to see. I think I included in a poll how the time works out because it seems like it works good for all the entire nation. Now, I don't know what's going to happen if we ever get a world audience, but who knows? But anyway, Andrea mentioned that Viagra should not be taken with antihypertensives or tamsulosin. Did she mean that they should not be prescribed simultaneously? Or did she mean that they should not be taken simultaneously? In other words, could a patient take their hypertensives and or tamsulosin in the morning and use Viagra in the evening? If the latter is true, how far apart can patient safety take them? And Andrea's not here today. I don't know, Lori, do you have any thoughts on that?
I think that what I've usually told people is 4 hours apart. So I know that tamsulosin, the best time to take it is a half hour after dinner. And then I tell patients to wait a few hours and then take the Viagra.
Okay. Yeah. And I think what she was alluding to is the fact that class of drugs can lower your blood pressure. They kind of boost the effects of antihypertensives. So, I mean, one of the things that we warn people, like drugs like tamsulosin that do the same thing, is the orthostatic hypotension. You stand up and all of a sudden your blood pressure drops, and the crowd that's using this is not the younger folks as it is. So, a little less balance and a little drop in blood pressure could be a fracture. So I think that's where she was coming from. I know that we have patients that have, a large number of people on antihypertensives, but I think that you do need to caution them. They should probably consult with their regular practice doctors because there may be a dose adjustment necessary. But that was a great question, great follow-up question. I do have something coming in here. Let's see. Thank you for having this every weekend. What a great resource. I'm a new urology nurse. Wow, that's great. Hey, and I'd love to get the questions that are anonymous, but if you could just tell us where you're from, that'd be fun too, because we could say that. But I respect that not everybody wants to have their name thrown out there, especially if you're new. There is no such thing as a dumb question, by the way. So
Yeah,
if you
for
have
sure.
any questions, anything that you think might be interesting, feel free to ask. The format is it's for you, and the weekend, every weekend we plan to continue. I announced earlier that there's only 2 weekends I've posted for the whole year of 2022. Not that we're going to stop in 2023, but was far enough for me to try to think about. There's 2 weekends that we're not going to have a program, and that's going to be November 19th, which is our SUNA conference. And that's the Chicago Metro Conference for those people that are watching that are in the Chicagoland area and want to really attend a great conference. Go to the Chicago Metro SUNA website. Chicago Metro is really the backbone of funding for this project because the webinars are not cheap. It's an add-on that it's not a free Zoom product, trust me. So anyway, we do have a link from our UroNurse website to Chicago Metro, and you can check out and learn more about the conference. All the information is already available. The other one is going to be in October, and I think it's October 2nd or 3rd. And that's because the big national meeting for SUNA is going to be there, and I'm one of the speakers for that meeting. So you can attend that one at New Orleans and hang out with me. Ha, that'd be fun, right? But it should be a great, not supposed to be, it'll be a great meeting. And I've been to New Orleans several times. Some people don't like it. I love it. It's great food.
I love it too.
Great music. Yeah. So, oh, good. I don't see a question, so I am going to switch to the Euro News. Let me just pin this up so I can read it. So a couple of interesting articles I was going through here. The incubation period for COVID-19 and how it's changed. So the original Delta or Alpha and Beta variants that were out, actually the approximate incubation period was 5 days. So if you were hanging around with a group of people and somebody said, "Hey, I tested positive," could have been about up to 5 days before you showed symptoms. Now the newest ones that have come out with the Delta and the Omicron, they're finding that there's a much shorter incubation period, like closer to 3 days. So I think that's kind of why we're seeing a little bit more uptick in the Omicron. I can tell you that from our own personal family, I just found out my father-in-law just came down with COVID a few days ago, and we hadn't been over to their house in over 5 days, and I feel perfectly fine. But it's out there. It's in little rural Indiana. It's still spreading just like everywhere else. Again, runny nose, cough, sore throat. It's no worse than most colds. So I think that we're gonna get through this just fine. But I thought that was an interesting article.
Curious, Vic, I'm curious about if anybody heard. So a patient told me about the medication they give to people, and I can't think of the name of it. But it literally, I guess their symptoms are one day and the next day they're gone. And I can't remember the name of it. Yeah,
absolutely. And it's maybe one of our attendees can write it. It's Parloxib. I can't even say it. It's an antiviral. And I told him, I says, if you're not feeling better, call your real doctor, because my father-in-law likes to call his retired friends who are doctors and get advice from them. I said, call somebody who can prescribe that. And he's got a regular doctor. So, but actually I drove by his house in the boat and he waved from the deck and said he was feeling better. So I don't know if he needs it, but the other ones have said that, some of their friends have taken that and it's like a 1 day, 2 day, and you're feeling better. Yeah. But of course he's feeling better in 2 days, no matter what. He'll tell you it's his Viking blood. since we're talking about the latest pandemics, monkeypox. Well, I think the media loves to make something out of nothing, but
Yeah.
I thought I'd throw this in there. I saw an article about what the symptoms are. I haven't really paid too much attention to it because I'm not really all that concerned. But fever, muscle aches, swollen lymph nodes in the neck, armpits, and groins, a rash that can look like small pimples or blisters, usually on the genitals, anus, face, chest, and hands and feet. These symptoms typically develop within 4 to 14 hours after exposure to the virus. And the CDC's recommendation is minimize skin to skin contact. So this is not a respiratory virus. It's really not something that people need to be worried about.
Yeah.
You had much concern in your office about monkeypox?
I've never seen anybody with monkeypox. There is no concern here.
Oh, hey, our group is coming through for us. That's Paxlovid.
Thank you.
I was stumbling through
I know.
it, but Paxlovid is the medication, and yeah, I heard that is a game changer. So good to have the audience. Thanks. I'm just gonna clear some of these questions out so I can see any new questions that come in. And I think that was it for those. I think at this point, since we don't have any questions, anybody in the audience, feel free. Anything you wanted to talk about, Lori?
No, I love the talk on the MRI part, with the PSA and stuff. And I think the MRI is definitely something to look at. I think that from our observation with the MRI versus the PSA, and I think it's really come a long way. I want to get people's opinion on some insurances don't cover MRIs for this. And I don't know if there's anybody in the audience who have come through this before or come about this before, as far as them not covering an MRI for an elevated PSA. And we have to get prior authorization, and what do they do to try to get this approved?
Yeah, that's a good thought. Anybody in the audience has a thought on that? Why don't you end the question? Otherwise, I'm going to take a second. I'm going to switch over to the slides. So just give me 1 second. I'm going to disappear.
Bladder.
And I'm back. I don't know how you like that magic trick. Hey, live TV. I really ran out to get a paper towel because I spilled my coffee. All right. Note to self: finish coffee.
Vic, I just said bladder irritant. You just spilled your bladder irritant.
Oh, hey, we have a comment here from John Lynn. 1 hour spacing between Tamsulosin and PDE5 worked well so far. I raise my hand. All right. So thanks for that comment, John. We've been impressed. We've actually had some urologists join us. John Lynn is a urologist out of Arizona who's been watching our show, and going to try to get him on as a panelist. He does a lot of stuff on Facebook Live. So if you check him out on Facebook, and he does on billing, which is, I know we have a lot of advanced practice people that are in the audience. So it's be a good idea to check his program out, learn more about billing, and we're going to try to get you on the show, John, to talk about billing too. So hopefully we'll get you to join us as a panelist. Oh, and by the way, the name of that Facebook is the Thriving Urology Practice Facebook group. So check it out. I have. There's some really good stuff up there. So, all right, we're going to switch over to, let's see. I gotta find my, oh, share my screen here. All right, very good. So today we're going to talk about anesthesia in the office. Common office procedures that we're utilizing anesthesia for are prostate biopsy, vasectomy, cystoscopy, and BPH treatments like Resume and UroLift. We'll start with cystoscopy. So anesthesia, typically it's local anesthetic, lidocaine jelly, 5 cc's to 20 cc's. There's kind of a big debate as to what the volume that people use, and dwell time, 5 minutes to 20 minutes. Big debate over that too. Actually, there's a even bigger debate as to whether you need to use lidocaine at all. So I'm going to go into a couple of the studies that are out there, and then I'll give you a little bit my own personal thoughts on it. But as you can see, the lidocaine is, if you're not using it, it's comes in a little syringe that you can, has like a urethral tip. You place it into the penis, push on the plunger, and it'll instill the amount it comes in. Glido, the product I have shown, comes in 11 cc's and I think it's a 5 or 6 cc volume. So the first thing I like to talk about is the whether 2% lidocaine gel should even be used with the used for cystoscopy. Is it efficacious? And as you can see from this particular study, they had divided people up into 2 different groups, and the group 1, group 2 looked at the pain perception scores, and there really wasn't a statistical difference between the reported pain, whether they used a plain lubricant or used something that contained lidocaine. So the people that are on that side of the aisle are all arguing that, well, we're wasting our time. You don't need to use it. Just use a plain gel. Now, on the other side, I can show you some different studies about efficacy. And here's a study that was 4 different studies they looked at, and basically their conclusion was different. They said that their data suggests that intraurethral installation of lidocaine gel versus plain lubricating gel reduces the likelihood of moderate to severe pain during flexible cystoscopy. It's always the issue with studies is, how are they measuring it? Is there some, factors that are making, the data slant one way or the other? So again, I can tell you that I've had this discussion with some of my colleagues from SUNA, and we've, kind of argued enough facts on each side to agree to disagree. I still favor the use of using lidocaine during cystoscopy. I think it makes a big difference. It'd be a good thing for, feel free to put in any questions or thoughts that you have about that too, because I will take those after I finish my talk. The other thing to look at, as I mentioned, it's how much you use and dwell time. So there was a study I found that was kind of interesting. And this is one of the areas that I kind of had a lot of people, in our office disagree or question. And that's, sometimes they'll say, hey, the urologist does the cystoscopy. I just barely got the lidocaine in. And is it really doing any good? And so here's a study that I thought was pretty interesting. Now, they did 2 different types of lidocaine, lidocaine gel, which is, again, that Glido product, or using a lidocaine solution. And some people just mix lidocaine into, sterile water and instill that. And kind of did a study to see how well it worked. And it was interesting in that in the gel study, when they, and I'm sorry, they looked at how well it worked over using it instantly versus letting it sit for 10 minutes. In the solution, it didn't seem to make a difference, or actually it wasn't even as good if you let it sit longer. So it seems like the sooner you use it, the better. In the gel I'm sorry, I got this backwards. In the gel, the sooner you used it, the better. So as it sit longer, it didn't work as well. In the solution, you needed to let it dwell longer. So I think it gives a little bit of credence to my thought, is that, you can pretty much use it right away. And I've gone and utilized it in that manner by, whenever I put a catheter in a male patient, I'll put a little of the lidocaine in there first, and then pretty much follow it with the catheter. Now, one of the things that I, in my head, used to as a reference point, I've never had a cystoscopy. I've had a catheter, but it was put on when I was under anesthesia. So I don't know what that feels like during the insertion either. And I'm not about to try it just because I'm taking one for the team to find out. But I have had dental work where, it's probably like most of us, you have your teeth clean. And at my dentist, the hygienist just goes in and cleans your teeth and doesn't use any type of anesthetic. And then I got referred off to a periodontal person to check out to see whether, I had gum disease. And he said, well, welcome to the world. Everyone's got gum disease. But anyway, he said his recommendation was to have his periodontist, the ones that are trained, their hygienists, clean my teeth every other time. So I agreed to that. And so I went in and saw their specialist. The first thing she did was put topical lidocaine on my gums. Instantly, I could feel my tongue go numb. I can tell you, I hardly felt that cleaning. So if I had to say a cleaning at the dentist on a scale of 1 to 10 is about a 6 or 7 in pain, the cleaning at this hygienist at the periodontal office was probably a 2. I mean, it's a mucous membrane, just like the urethra is a mucous membrane. It absorbed the anesthetic quite well. And it was, for me, a much more tolerable procedure. So I'm all for it. If you're going to use lidocaine gel and you want it to stay inside, you do need some kind of clamping device to keep it inside the urethra. I offer 2. This one is about $35 and it's reusable. So does have to be reprocessed, but you can reuse it. This one's about 4 cents. So you can guess which one we use at my office. We did use the $35 one and it worked out fine. Only my staff tended to lose these quite a bit. They went out with the other paper products. So we're going to move on to prostate biopsy anesthesia. The periprostatic nerve block is the gold standard. There are some people that are on the bandwagon for using perianal interrectal lidocaine and prilocaine cream. Again, mucous membrane can absorb it. I can tell you that my thoughts on this is we have used it, and I do a lot of prostate biopsies. I've been involved with them my whole career, and I didn't really see a lot of good anesthesia for patients that have a normal rectum and somebody who's pretty good at placing that probe. And there's a little trick to having a skilled practitioner that helps. But as far as I'm concerned, I don't really see a lot of use for it, and I'm not sure it's the best thing to add. I don't think it does any harm, but I don't really think it's made any big difference. My thought is because the rectal vault is so big, I don't know if it gets good contact with the area you're trying to numb. So I'm just not pleased with it. However, that said, there are cases where I do think it works out to help. And that's patients that have had like some kind of rectal surgery where they've, had hemorrhoids removed or something, and they've a very narrow rectum. It's going to be difficult no matter how you try it to get the probe in. And I think anything you can do to try to help relax or loosen that up makes a difference. So if you feel that they've had, a history of a fissure or hemorrhoids, and you feel that real tight rectal sphincter, not so much the sphincter, but scarring there, then throw some lubricant with the lidocaine in there. and see if that helps the probe go in easier. So I'm not sure if it's the extra lubricant that helps or the lidocaine, but I'm a fan of it for that. Now, of course, that skilled practitioner part, all the lidocaine in the world is not going to help you with this guy. So let's talk about the periprostatic nerve block, kind of the gold standard. Again, been doing biopsies a long time. We didn't use anything in the beginning. Then they started trying to utilize a lidocaine block, but I don't know that it was well thought out or found out what nerves you needed to block and how to best block the pain. But we do it now all the time, and it makes a huge difference. There's no question, big time difference by using anesthesia with the nerve block. And I've got an ultrasound kind of show you what that looks like. So this is a sagittal ultrasound. So we're cutting the prostate the long way. So there's a prostate seminal vesicle. You can kind of see bladder there. There's an area between the prostate and the seminal vesicle, kind of refer to it like a triangle area there. That's the best place to place the block. It's done on the right side and the left side. There are some that will do a block at the apex of the prostate also. For prostate biopsy, I've got 2 physicians I work with all the time. One does both blocks for prostate biopsy. One does just the one block. Patient tolerance, I can't tell the difference. I will say that the patients who have the apical block have more discomfort from the block. It's a little more sensitive area than the base, so they feel it more. But the one use that I do think it comes in handy for, and we'll talk a little bit about the use of this block in our talk for BPH procedures, is when you're doing something like a resume or a urolift, it does help to block the apex. I think that it helps to relax the sphincter a bit so the scope passes easier. That's just a guess. It's not, there's no evidence to prove it. Good research to maybe look into that, but I noticed that the scopes seem to go in a lot easier when they had that front block. So the urologist who doesn't do that for prostate biopsy does do it for his resume and urolift cases. So we do kind of feel that that does help. Anesthesia for vasectomies. So the choices are local anesthetic, our friend lidocaine with, sometimes some doctors will add epinephrine to decrease the bleeding, topical anesthesia, oral sedation, and nitrous oxide. We always instruct our patients to shave ahead of time. It just makes it, first of all, patients are going to tend to be very careful down there not to cut anything. And it's just a lot easier than having all this hair all over the place trying to get rid of that can get in the way. So if they do it ahead of time, it makes a lot of sense. So it's a perfect opportunity to let them apply a topical anesthetic. We use EMLA cream. We prescribed that at the time of the procedure. And the thing with EMLA is it has to be, this is not a mucous membrane, so it takes contact time for it to work. So they need to be instructed to leave it on at least 60 minutes before the procedure and use an occlusive dressing. And we just recommend like good old saran wrap. So they shave before they come in, they put this EMLA cream on, and they come in with the saran wrap over their scrotum. And I can tell you that the patients do not feel the local anesthetic when they're the needle prick when they're getting the local anesthetic for the block. It makes a huge difference. Orals, the ones that we typically use are Xanax, Valium, and Ativan. Any of those drugs work great at decreasing at least the anxiety, not necessarily the pain, but they just feel a lot better. It's a younger group. Older folks, I kind of worry about the risk of falls, etc., with those drugs. But since most of these are younger, the problems is they're very slow onset. So you have to have the patients take it at home ahead of time. And it take a long time, 6 to 8 hours to wear off. So they're going to be kind of groggy and useless for 6 to 8 hours. Some people don't like that. I'm being one of those. I don't really care to have that sensation for that long. Again, no driving because of the danger of being in, getting in a car accident because of the effect of the medication. So you have to be aware of that. And that's where our friend nitrous oxide comes in. So we'll talk more about that when I get through my BPH anesthesia. But we have used it with vasectomies in our office. It can be used with probably just about anything, any procedure. but office BPH treatments, and those are the Resume and the UroLifts. I'm not going to talk about those procedures because tune in next week. That's going to be our subject. We're going to take a deep dive into Resume and UroLift, and Dr. Herbert User will be the one giving that talk on those two. So tune in for that. Next week is Labor Day weekend, so it's a little different format. We'll probably get right into our subject right away, but we'll take some questions and answers because we do have a good panel that's still going to be with us. So if you have your general questions, but this one will be a little bit longer talk. I think it's going to be about a half hour. The choice for this is lidocaine jelly. Again, we're doing a cystoscopy, so just treat it like a cystoscopy. That works well. Prostate block and nitrous oxide. The lidocaine jelly, and I don't know if it was a company or this is somebody's idea, but talked about chilling the lidocaine ahead of time, putting it in the ice box and then using it cold. I don't know if it makes a difference or not. I don't think there's any good studies. If anybody knows a study about using chilled versus non-chilled, a lot of the patients that I use the chilled complained they didn't like that sensation of it being cold. So I tend not to use the chilled, but I don't know that it makes a difference. But if you know any good studies out there, I'd be glad to read them. So the nitrous oxide is the latest thing that we've started using. And I think it's getting adopted more and more throughout many practices, including urology. It's a depressant, so it slows the body down. Once it kicks in, makes you feel happy, giggly, lightheaded, mild euphoria, and mostly relaxed. The big difference, and we've had some doctors early on try nitrous oxide by itself and do a UroLift or a Resume, and you can, but those patients are pretty uncomfortable. Add a prostate block and the nitrous oxide, and these patients are doing much, much better. It just takes the edge off. I think it knocks the pain down a little bit, but it just makes the patients a lot more relaxed. And some of them really, it's amazing how different the sensations are for different people. Some will say, it didn't do anything. Others are like telling you that, wow, this was the greatest thing in the world. We had one patient that kept telling the doctor and I how much he loved us. So, you can lose some inhibitions, I guess. So it is interesting what happens under the nitrous oxide. But this is what it looks like. There's a couple different companies that make it. We happen to chose Pronax because it's simple. It's there's nothing but an on-off switch for the unit. And basically it delivers a 50-50 mix of nitrous oxide and oxygen. This is what it looks like when we're having the patient. We use the mouth breather. The nice thing about it is it's safe, been used for decades. Dentists have been using this for a long, long time. It's self-administered. So patients kind of, if they're getting too groggy, they can take it out of their mouth and lay off of it. If they were getting sedated enough to the point they couldn't hold it in it, they would drop it. You do need somebody there to kind of monitor and watch the patient, but they're in control. It's not like you have to have them on monitors. Quick onset, this is the best part about it. So typically the way we would do a Resume is when or UroLift is when the patient's going to get the block, we start them on the nitrous oxide, give them the breather, tell them take a few deep breaths, and then just breathe normally. And by the time you get the probe in, you can give the local anesthetic, and you can tell it's definitely easier to give. We could use it for prostate biopsies too. So some patients do want it for that, and it helps that procedure. So works quick. Best part, short duration of effect. So as soon as they stop utilizing it, it clears from their body within minutes. So normally when we're done with the procedure, and not normally, when we're done with the procedure, we just tell them, all right, stop it. We take it away from them. And by the time we get the catheter bag secured and everything, set, we ask them how they feel, any effects. Once they seem like they've cleared and they're normal, they can sit right up and they don't have that hangover effect from it like you would with an oral medication. And it can be used for the duration of the procedure where patients are having any issues or pain or anxiety. So if it's a longer procedure like, resume is a really short procedure, 15 minutes at probably at most, including putting the catheter in. Urolift is the longer procedure, but still 15 minutes to 30 minutes time. But they can be used for the whole duration. Most common side effects are dizziness, nausea, vomiting, fatigue, headache, excessive sweating, and shivering. But only about 5% of patients experience these side effects. Now, I can say I've been involved in hundreds of these cases, so I've got a little bit of knowledge from seeing how the effects are and what patients complain about. The only side effect I've ever observed out of that list is shivering, and it's pretty rare. I mean, probably the 5% is dead on. It does occur, and I think the patients, to me, that had this side effect were the ones that were really hitting the nitrous pretty strong. Sometimes you have to warn patients, just breathe normally. They'll get a little pain and they'll start really huffing and puffing on it, and you don't want them to do that. Now, there are some absolute contraindications, and it has to do with the use of oxygen or the nitrous oxide. So for the oxygen, if they have severe COPD, they shouldn't do that because the oxygen can affect the triggering mechanism for breathing. So if the high oxygen levels can make it so they won't want to breathe. And a history of taking bleomycin because it can cause lung injury, oxygen. So higher, the normal levels of oxygen can cause that. So make sure that whoever's, if you're going to start using it in your office, whoever's there and in charge is aware of these things. So the nitrous oxide has another issue, is it's easily able to diffuse into air spaces. So anything that would involve creating an airspace is a potential danger. So like when they do those procedures where they put a little air bubble in the eye to help the retina to stay in, from detached retinas, you have to wait at least 3 months for that to dissipate. If they've had some previous history of middle ear surgery, pneumothorax. So you see all these things that produce air, bowel obstructions, and alveolar bullae. Also, patients that are chronically malnutrition, critically ill, or have a condition that can alter their vitamin B12 or folate storage synthesis. Again, typically not the patient who's coming in for a procedure like a urolift or resume, but keep those things in mind. And then again, pulmonary hypertension. It can exacerbate the pulmonary hypertension. So again, very safe. You have to know what you're doing, though. You don't want to just bring it in and not have people trained. And I can't talk about all these lidocaine blocks and not talk about the shortage that we're experiencing right now too with lidocaine. So why is it short? Well, part of it, I think, is like when COVID came and all of a sudden toilet paper was short, people just started storing this stuff up. Why they chose toilet paper, I don't know. But I know with lidocaine, there was a company that was making it, that quit making it. Most of our drugs we know are manufactured in China, and China does strict shutdowns during their COVID outbreaks, and that's shut down factories. So that's caused manufacturing delays. And I think all of that sort of make people want to store up, and we're guilty as anybody else, so that, I don't care if we're short, just as long as I don't run out. And that's the mentality. Keep in mind that sometimes looking at different quantities or percentages, vial sizes can sometimes, one size is short where another size isn't. So if you want to try to make sure you're getting what you can, do a little bit of work and you'll be able to find it. And then before I got on, I did a quick search at the Henry Schein website, and I tried to order what we use is the 1% lidocaine in a 50 ml vial. So I tried to order the most you want, the most you can. So I put in 10 to see if I could get 10. And what it did do is it reduced it down to 4. So I could only get 4 boxes. So it'll automatically do that. But, that's 4 boxes is better than no boxes. So that's my hint for you, my tip. If you're worried about the shortage, look at multiple places to try to buy it. If you're part of a big buying group, that can sometimes help. Visit those sites frequently. And yes, I know I am encouraging hoarding, but if it's me, I'm going to make sure I've got the supply I need for my patients, right? And at this point, I'm going to stop sharing and we're going to go over and start looking at our questions. And sorry for the delay. Takes me a second to switch out of that. All right. It just took me a while to get my screen back so I could see what's going on. All right. So we have had some questions coming in here. I'm going to. So Melanie Waddlington said, good morning. I'm a CURN from Oregon. We have not had a patient with an insurance that will not cover the prostate MRI, but some insurances are not contracted with the facility we usually refer patients. In this case, we have to hunt around the state to find a contracted facility. What did you think about that, Lori? Do you see that any help to try other places to go, or?
We could. I think the problem is that a lot of insurance companies will only cover the MRI if the patient has prostate cancer. And they're following up on that. So, and then also, excuse me, if another MRI facility is approved, we have to make sure it's a 3T MRI because there's certain prostate MRIs that we prefer over others.
Yeah. So yeah, I think it's a valid point that sometimes I think you need to see where you can try to find for patients. You know, we try to do a lot of that legwork ourselves too for the patients, find out who we can refer to. John Lynn sent in a few questions or a few things here. Where can you continue UroNurse discussions anytime? So anytime is not available yet. We're not quite to the 24/7 format. But after this finishes, when we conclude at 10 o'clock, we do have our after party. And if you go to uronurse.com, there's a link. You just touch the button that says after party. It'll instantly transport you into the after party where we can just hang out. So it's kind of a fun thing to do. And we've had a lot of people do that in the past. So if you want to join us afterwards, also the links that you get, you should be getting like a reminder on the day before and like an hour before. That link is also found in your email. So if you go back to your email, there's a link. It's a Zoom meeting. So you'll be able to get your microphone live and talk live. It's be seen live. John Lynn also said for the skilled urologist, no lidocaine is needed for 99% of the patients. John, I am 100% on board with that one. There is no substitute for skill.
I'm going to talk on that one.
Go ahead.
And I totally agree. And I think that in our office, we don't use it on females whatsoever. Females, no way, you know, 1.5 inches going in the urethra or whatever. We do use it on males. I think it's more of a psychological thing than it is that it really helps. I think that they think they're going to get this numbing thing and it's going to be great. And I think that makes it feel better for them. I also use it on suprapubic tubes a lot. And I think it's not for the numbing effect. It's the you know, it goes in a lot easier. And even when I do Foley's, I put it in because the Foley's go in a lot easier than just putting the jelly on the end of the catheter. So that's my opinion on that. And then I also wanted to mention with the Glido, for cost effectiveness, we used to use, like you had shown a picture of the 11 cc's of the Glido. We only use the 6 because it's cheaper. And, you know, the 11, we just don't see a difference between 11 and 6. So,
yeah, I agree on that one too. We use the 6. The 11 is the one that they use for the BPH procedures. I'm not sure why again, probably no science behind it. If anybody's read some good studies, I looked through a lot of stuff this week to see what I could find. There wasn't anything out there. but I do agree. It's just the psychological impact is huge, and you can't be undermined that how much psychological effect there is. A real quick story. There was a patient I was seeing in the hospital that I was called up because they couldn't get a catheter in him, my typical call. And he had already had a nurse try to put it in from the floor, a resident try to put the catheter in, and now I'm the third guy to come along and try to get this catheter in him. And he's like, "Oh, come on, dude." He says, "Take me down to the operating room, and this is ridiculous." I'm like, "Well," I says, "I tell you what," I says, "I'm the urology expert, and I'm going to be able to get that in one shot." Now, of course, did I know that? No. I mean, it could have been a stricture. But what I was going for was the psychological part. Again, I did use lidocaine gel, which I don't know if they did previously, but the psychological of, I'm the expert. I'm a urology expert. I've done this a million times. I'm going to get it in one shot. And I said, just relax. Now, one of the tricks that I use when I put a catheter in is I kind of lean my arm a little bit against their inner leg, and I can kind of feel when they're tightening up their sphincter from the muscle in their leg. And when I feel that relax, that's when I push. And I did get this successfully placed in one shot. Patient was thrilled. Next day, we're making rounds. The urologist and I were together, and I walk in the room and he goes, "Hey, one shot." So that was my new nickname. But I think it goes along with what you're saying as far as the psychological impact of doing that. And you know what? It's not going to, I've never seen anybody have a reaction to lidocaine jelly ever in my career. All righty. John Lynn said that if you want, you can continue 24/7 conversation at his Thriving Urology Practice Facebook group. So there you go. Someplace to hang out too. Vic, could you please tell us where you got those articles from, please? Oh yeah, I didn't. So there's the Turkish Journal of Urology was one of them. I think probably what I'll do is I will try to think. I'll try to find a place I can post the articles. I'll put them up on UroNurse.com. I'll actually try to post those articles because I think that's a good thing to have those available. I should have thought of that ahead of time. They were there. And unfortunately, of course, every week we learn some new trick. The one trick I learned is when I put my slides up, and what Zoom does to the slides is it put my face over some of the slides, so I couldn't read everything, and I couldn't really read I had all the slides had the labels of where they were from, so I don't know if they were all that legible. But anyway, that's a good thought. I will add that to our UroNurse website. You guys are the ones that are the driving force. Robert Fullingham, where I work, we don't use nitrous oxide or a block for UroLift. What have you seen with pain levels and the effective treatments for pain in the days following the UroLift procedure? That's a good question. Do you guys do UroLifts, Lori?
So we do UroLifts in the OR right now, but at my previous office, we did do UroLifts in the office. And from what we found, so this is the experience I've had, is that when we did UroLifts in the office, we would have people come in 2 weeks early. And at that time, they would sign the consent because we know that we're going to give them usually Norco and Valium beforehand. And then we would also put in like 10 cc's of lidocaine, the Urajet or the Glido. We would put 50 cc's of lidocaine in the bladder and let it sit for a half an hour. We'd follow it up with another 10 cc's of the lidocaine, let it sit for about a half an hour, and then they would do the UroLift. And actually they did really well. And the pre-op appointment for us was ideal because we were able to tell them their expectations afterwards. I mean, I don't know how much I could tell these people. You need to drink a lot of water. You're going to have blood in the urine. You may or may not go home with a catheter. We don't know. The urgency feeling that they have to go to the bathroom is intense those first couple days. And for them coming in 2 weeks prior and explaining all this to them they knew what to expect. So it was so much better for the patient. So we didn't get call after call after call after the UroLift was done. And so that's what worked for us. Right now, we're doing UroLifts in the OR. We want to do them in the office, but there's some walls right now for us to do them in the office. So we're trying to, but from previous experience, that's what we did.
Yeah. How about post-op instructions? Do you have a routine for that?
Oh yeah, absolutely. And the biggest thing that I would reiterate to people is those bladder irritants afterwards. Stay away from this, away from this, because this is going to make it worse. Drink a ton of water. And people tend to, because they want to go more frequently, the more urgency and whatever, they would stay away from water. And you can't do that. It's going to make it worse. And they don't understand that stuff. So post-op, we definitely gave them post-op instructions, post-op, information as far as what to do, what not to do. And people did great. They did, as long as they knew.
Yeah. I think that's sometimes overlooked, the post-op instructions. I know that at least when we did our surgical cases, we always give them a pre-op instruction sheet, which has post-op instructions as part of it, but patients lose everything. They're just irresponsible. Most patients, I shouldn't say all, but most will lose everything. So, the ones we do in the office is a great experience for us to be able to give them a handout of here's what you should, as you said, expectations. Here's what you should worry about. Here's what you don't need to worry about. Because again, we put a little, local into the prostate through the rectum. So they're going to maybe wipe themselves and feel a little bleeding or see some blood on the tissue, not to worry about that. But if it's heavy bleeding, of course, let us know. So all those things we can give them in a piece of paper to take home and hand out. I can think with the opioids issue, our guys are really, hesitant about using Norco and things like that to treat for pain. But I think a lot of people underestimate the healing or the pain properties or, how good a pain reliever plain old Tylenol is. Because I had, major back surgery, and I kind of alluded, I don't care for that weird feeling you get when you take narcotics. And I switched over to plain Tylenol pretty quickly after the procedure. And if you take it around the clock for surgical pain, it works. Around the clock, it'll pretty well take care of the pain and you can still function. So I always recommend if they're having discomfort, just take a Tylenol, give that a try. And have you used any of this azo stuff that's over the counter?
Yeah, I was just going to mention that too, because yes, we definitely, it's azo over the counter. We always recommend maximum strength. There's a ton of azo products out there. So we tell them, if you're not sure, just go to the pharmacist, find out what's best for your symptoms, because there's so many azo products out there right now.
Yeah. That's a good point. We do recommend it if they feel they want it, especially because the big complaint we have, and I'm not sure, Robert, what your biggest issue was with pain was whether it's the pain or the irritative voidings, the frequency burning. And most of that's after the catheter's out. Everybody's going to complain about wearing a catheter, and I always tell patients, this is not going to be comfortable. I am for the catheter discomfort, I'm a big proponent for taping the catheter to their leg. And I only do that because that was personal experience. I had to wear a catheter after surgery, and every movement where it was moving, I felt it. So I asked him, give me a piece of tape. I want to tape it to my leg. I've been doing this for years to my patients. I said, this way here, at least when you move, you're not pulling it against your bladder. And that, I think, makes it more comfortable. So that's one of the things I recommend.
Yeah, the other thing we recommend for patients, if obviously we have stat locks in our office, so that's convenient. But if we don't have stat locks, or the patient, their anatomy is such where you can't use the stat lock because it can even pull, we recommend that leg bag is always above their knee. Don't put it below your knee. Always put it above, so it gives you slack.
Yep. And patients are notorious for wanting to wear it below their knee. Given their choice, they'll put it below their knee because it's easier to reach. But if you look at your anatomy, there's nothing to hold it up. It's going to slide down. It goes from big to small, so it's going to slide down. or at least you got a nice knee to hold it in place if you put it above. So that's a good point. I had a patient who was wearing a long-term catheter. This guy was like quote unquote permanent catheter with a leg bag. And he came in one day, and you know how some of them had those little like slots for the buttons that the straps go through. He had his wife sew some buttons on his underwear. So he wore the boxer briefs, and his wife sewed buttons on the underwear, and he just put the leg bag on those buttons. I'm like, dude, you need to, patent this. This is a great idea because it kept it from pulling down.
There are so many things that people have done that are so genius. Like, yes. I'm like, I would have never thought of this. But you know what? Whatever makes you comfortable, let them do what they want to do.
Yeah. Now, what do they say? That's the mother of all invention is, necessity.
Yep.
So, well, very good. Hey, we got a great crowd out there. A lot of folks tuning in. I see some of the names that I've seen before, so it's good to see a lot of repeat people coming in. I'm glad that I've had the comments to tell us that you enjoyed it. That means a lot to us. I'm trying to think if I had that's not what the one I had. I was trying to see if I thought I had a poll that I was going to send out, but I did. I'm going to throw a quick poll out just for fun. This is a follow-up to the telephone triage one, just for my own curiosity. So there's lots of things that the webinar allows us to do. Polling is one of those quizzes. There's a survey that will come to you after the meeting. So you fill that out. That again gives us some good information. A lot of times it's repeating what you did before, so I'm trying to change it up a little bit. I'm seeing the questions that are coming in here. We've had 56% of you have participated in the poll. That's not bad. So right now, it seems like most practices, so the question was, who does telephone triage in your office? And the choice was, is it the nurse, the RN, the MA, MD, or do you have a call center that's taking those calls? And it looks like by far the majority of the offices are utilizing an RN to screen this. And I think that's telephone triage. That's a dangerous practice because, some people start giving advice that shouldn't be giving advice. Or misinterpreting. I think that, probably the best person to have in charge of that is an RN. So I'm glad to see that. So, okay, I'm going to end that poll. I'm sharing the results, so I don't know what that does, but again, I'm going to learn every week something new. Good. Let's see, our office actually got, this is from Abigail Ricardo Edworthy. Our staff actually got our stat locks this week. Shortage of stat locks. I'd like to say that's going to get better, but I think we're going to see a lot of these shortages for a while until manufacturing starts to return back to the US or, other areas. I think that a lot, one of the things that we're going to see changing in the world is people are realizing you can't get everything. We all like to get the cheap, inexpensive labor of China, but you can't put all your eggs in one basket. Something happens in one area, such as a pandemic. I mean, not even, bad politics or things, but something happens and you're reliant in one area, you're going to suffer. So I think we need to start seeing manufacturing moving around. But and thanks for that update though. So good thing you got your stat locks, Lori. I think you must be muted. I see your mouth moving.
We do have an abundance of stat locks.
Good.
Good.
Of course, you can always take silk tape and make your own, but the stat locks, I will say, Stat locks are really a great item because they'll last forever. I'll put one on a patient 6 weeks later, they come back. It's still there.
Yeah, and they tell you to remove with alcohol, the alcohol pads. Yeah, that doesn't work. We have the
Yeah.
adhesive tape removers in our office. It takes a little bit, but we can get all that adhesive off of them because alcohol does not remove them.
All right. Well, we hit our 10 o'clock hour. Thanks for everybody for showing up. We are going to open up the after hour. If anybody wants to come and just hang out, it's informal, just ask questions, talk to each other, whatever you want to do. We're going to open that up. So just click that link. And at this point, we're going to end the webinar. And I do appreciate everyone and see everyone next week. Thanks again, Lori, for all your help.